termed, sorry, I've just got to say, got it to recording. Yes, how we've termed tendon pain. And we realised in the early 90s that it wasn't an inflammatory condition. So that immediately created problems for us in terms of using tendonitis as how we described it, because itis means inflammation. And if it is an inflammation, then that's an incorrect term. So then we started to use tendinosis, sort of trying to represent that this was a degenerative condition. And then in about the 1999, we realised that they're actually pathological terms. So they describe what's happening in the tendon, and as clinicians, we don't know what's happening in the tendon. We can't tell from the person's pain or presentation or even from imaging what's happening in the tendon. So that seemed a bit silly as well. So what we then devised was a term that was clinical. So tendinopathy is the clinical term for pain and dysfunction in a tendon without accounting for the pathology. So it's really the correct term, because unless you can go into a tendon, take a little piece out and work out exactly if it is tendonitis or tendinosis or some other condition, you can't call it those terms. So it's a little bit pedantic, I guess, but I think tendinopathy is such a much, much better term because it doesn't tell us anything that we don't know from a clinical perspective. That's really where we're diagnosing and managing tendons from.
All right. So from a global, very generalized statement, but we do feel that it's trickier to treat tendon injuries than muscle injuries. So can we hear a little bit about what's your perspective, whether this is actually true, not true, if true, why?
Yeah, it's there's a couple of reasons. The first thing that's the most important is muscles tell you when they're unhappy. So you do a hamstring strain, or you do too many hamstring curls and you get delayed muscle onset soreness. That's the muscle saying, I'm really unhappy with the load that you've placed on me. With tendons, they keep absorbing the load and they keep taking it, and they might be unhappy with it, but they actually often don't tell you. So there's no way that you're aware that your tendon is being overloaded, because we see so much asymptomatic pathology. That is, the tendon has a degeneration in it, but people have never had a symptom in their entire life. So we don't get the pain messages from tendons that we do in muscle. And that's somewhat down to the fact that there's a lot less cells in a tendon comparative to a muscle, but it's also about the pain nociceptive driver of tendon pain. We know that there are only a very few nociceptive nerves in a tendon. You can't have nerves deep in a tendon because they get squashed every time that the tendon contracted. It's not contracted, so every time the tendon was used. So we have nerves around a tendon, and we have nerves at both ends where it attaches to the muscle and where it attaches to the bone, but we don't have nerves in the tendon. So we don't have fabulous warning signs from a nerve perspective that something's going on. And so we don't hear our tendons until they're right at the end of their tether, where they've really had enough. And that's when they'll start to give you some pain signals. The really important thing about tendinopathy is that we actually don't know the source of pain. We don't know if it's the cell that produces the nociceptive substance. We don't know if it comes from mechanical processes like tearing of collagen. We think it doesn't, but there are possibilities around that. So not knowing that makes it really difficult for us to work out why tendons get painful. We sort of know from a clinical perspective, but from a physiological perspective, we actually don't understand it very well at all.
So is there anything that's related to the actual structure of the tendon that, gives all of these different sort of symptoms rather than the muscle? If yes, what kind of structural difference are we looking at that's, making the tendon peculiar in terms of, condition diagnosis and recovery?
Yeah. So tendon, because the tendon is very slow to do anything, we don't have a lot of cells, as I said, and it's extremely slow to respond to loads and stuff. So again, it's just a process that takes a lot of time for us to work out, or for our brain to work out there's something going wrong. What we do know is that you can't have tendon pain unless you have pathology, but you can have pathology and not have tendon pain. So that's a really important distinction for everybody. If somebody has pain over a tendon and their imaging is normal, that is, there's no changes in the tendon, then it must be something else giving you pain. If your imaging is abnormal and you have pain in and around a tendon, it might be the tendon that's giving you soreness, but it might not be. So you can't make a clinical assumption from where the person tells you their pain is and from what you see on imaging that the tendon is the source of the pain. You actually have to have much better clinical skills to work that out. I'm not sure I answered your question. I hope I did.
No, a little bit, maybe. So again, the tendon is like a new world for us, right? So it's going to take us a little bit of time to grasp on what you're trying to say. Okay, just continuing on to this question. We have tests that tell us about whether the muscle is in its optimal length or not. However, for the tendons, we don't really know how to particularly assess the length of a tendon, or how to realize if the tendon is actually not at its optimal length. Is there like a term of optimal length for the tendon as it's like there for the muscle?
No, there isn't. So tendon length is very much determined morphologically. That is, it's almost as though your genetics tell you how long your tendons are going to be. So if you think about looking at a group of people from behind and looking at their Achilles tendons, some will have very long, thin tendons. Some will have almost no tendon that's right down by the calcaneus, and some will have cilial tendons that cilial muscles that come down very low in the tendon. So there's actually not very much tendon length. So the length of the tendon is pretty much determined by your genetics. I don't think you can change that. So we don't stretch tendons and we don't stretch muscle tendon units. What is really important in a tendon is how compliant it is. So we know that tendons stretch and return energy. So that's the energy storage and release part of how a tendon functions. It's how stretchy that tendon is that's important. So you want a tendon to be not very soft. So you don't want it to be able to stretch a lot when you put a load on it. And you don't want it so stiff that it doesn't stretch at all. You want something in the middle. So you need a stiff tendon, because the stiffer a spring is, the more energy it can store. But we can't determine that. And the literature is all over the place about how much tendons stretch. So some people will say 4 or 5%. We did some research many years ago that showed the patella tendon could stretch 16%. So it depends on the tendon, it depends on the person, it depends on the structure, the morphology of the tendon in that person, their loading history. All of these things actually change dramatically how compliant or how much a tendon is stretchy. But the actual length, starting length, is not important, and there is no need to go stretching tendons or muscle tendon units if you have a tendon injury.
Okay. Just another point of comparison between the muscle and the tendon, like how we have been, talking so much about the fascia that covers the muscle and how that could be the reason of pain or stiffness, or the, cause of, part of cause of a problem.
Yes.
Tendon also has its own covering, right? The paratenon. So, and the paratenon be involved like the fascia is involved? And if so, is there any way to know if the paratenon is involved or not?
Okay, there are so many questions in what you've just asked. What we're realizing, of course, is later in our research, and this is Hazel Screen's research from England, is that there's a lot of connective tissue in tendons as well. So we've always concentrated on the actual collagen fascicles, the collagen in the tendon. But what we're realizing is that most of the load, or much of the load, might actually go through the internal connective tissue of tendons. So we have an internal connective tissue, and we have an external connective tissue. And they seem to have quite different functions. The internal connective tissue is about the spring-like load. That seems to be where we store the load. The external connective tissue, the peritendon, and there are many terms that you can call this, and we don't know very much about these structures at all, are there to allow the tendon to glide against the surrounding structures. So that's a way of relieving friction. And we get irritation in the peritendon structures, the connective tissue around the tendon, by doing too much movement of the tendon without load. So you might find somebody hops on a bicycle, it's not quite set for them, and they do a lot of sort of big movement, plantar and dorsiflexion. The tendon will move against the surrounding structures and you'll get a friction type load. Now that presents really differently from a tendinopathy, and your clinical history and your examination will actually tell you if it's a peritendon in isolation or a tendinopathy in isolation, or in fact you can have both in some tendons. So if we think about the lower limb, it's really important. Lower limb is my expertise. Not every tendon has a peritendon that gets us into trouble. So we have an Achilles that has just gliding membranes. It doesn't have a tenosynovium. But all our foot and ankle tendons, our peroneals, our tib post, our FHL, all have tenosynoviums. So very complex peritendon structures. So it's very tendon specific as to, and load specific as to whether you'll have a peritendon problem. And if you do, you have to be clinically good at differentiating whether it's a peritendon or if it's a tendinopathy, or both.
Okay. I believe that's another topic that we'll have to reconnect
Yes.
on. If I ask you even one more question about peritendon, then it's all going to go towards the peritendon. So I'm going to save that one for later. Okay, you mentioned collagen, how we've been focused on the internal connective tissue, which happens to be the collagen matrix. So one of your podcasts, you mentioned that as soon as we start loading the tendon, there are changes that you see in the collagen matrix. So what sort of changes are we exactly at the microscopic level? What sort of changes are we actually looking at?
Okay, so the extracellular matrix, that is the structure outside a tendon cell, is collagen and proteoglycans and other glycoproteins and a few other things as well. So if we do a lot of loading, we think we see mostly changes in the connective tissue inside the tendon, and it's going to be mostly proteoglycan changes. So we know we can upregulate proteoglycans relatively quickly, sometimes within hours or days, but we also know that our collagen is very stable. So there's some studies by Katja Heinemeyer from Denmark, and she showed that you develop all of your collagen in your young to teenage years, and then you don't develop any new collagen after that. So the collagen that you have in your tendon at age 20 is the collagen that you have in your tendon at age 80. So our collagen pretty much doesn't change. What we see is changes in the proteoglycans, the glycoproteins, the water, the connective tissue, and it depends on the type of load that we place on a tendon, how that changes. So it's really important to realize that you don't tear collagen in a tendon. It's not how we get an injury in a tendon. There are a lot of other structures that have to change before the collagen changes, and the continuum model will say the tendon cell detects the load, it changes its expression of proteoglycans, that changes how the collagen is structured, and then you get your vessels that grow in. So it's actually, your collagen is actually the third or fourth step in the whole process. So, yeah, it's really important to realize that your matrix is very stable and very competent, and the changes are in sort of the smaller proteins rather than the collagen proteins.
All right. Does like you said that the length of the tendon is genetics being one of the factor that dictates how the length of the tendon is. Does the type of collagen and the strength of the tendon also have something to do with genetics?
Yes, it does actually, interestingly, but it doesn't help us clinically. That's the most important thing. So, and it's interesting, it's not type 1 collagen that's been genetically linked to tendinopathy. It's type 5 collagen. So that's one of our organizing collagens. It's one of the collagen that gives us genetic diseases such as Ehlers-Danlos syndrome. And what it does is actually make tendons a bit stiffer, and that can actually make you a better athlete. And being a better athlete, you put more load on your tendon and you can end up with tendinopathy. So it's a very complex system, but you have to have a pretty profound disease such as Marfan's or Ehlers-Danlos, as I mentioned, to actually have changes in your collagen. You develop your collagen probably in your youth and your teenage years, as we talked about, and how much you develop is probably dependent on how active you are. It's not unlike bone. So we develop 25% of we deposit 25% of our bone in our prepubertal years, about 50% in our pubertal years, and about 25% in our early adulthood. It's probably the same for tendons. So actually loading in childhood and adolescence actually may be very positive for our tendons if we get the loading right. But tendon pathology, so most of the collagen in normal tendon is type 1. In tendon pathology, we see a lot more type 2 and type 3 collagen. And all the collagens in pathology are disorganized, so they don't allow us to transmit load. So that's the important part.
All right. So now we'll be following up with a few of clinical questions rather than the theory. So
Yes.
Nirja, over to you here.
Good.
Yeah, I think we can talk about the pathophysiology of things for hours. So like in order to catch this tendon pathology in its early stage itself, what would be the clinical cues you should look for in the history?
Okay. So the first thing that's really important is that you can develop all of this pathology with never having a symptom. That's the first important thing. So someone who presents to you with their first bout of tendon pain, tendinopathy, may have had pathology for a very long period of time and actually have a degenerative pathology. The presentation clinically, regardless of what's happening in the tendon, your first presentation of tendinopathy will be some sort of symptoms after an increase in load. So the critical thing in your history that you should be looking for is someone will come in and say, my Achilles is sore. And you say, what have you been doing differently? And they will say, it can be anything. Oh, I've taken up running. That's a simple one because it's much, much more load for the tendon. Or if they were an athlete, they might have changed their shoes or changed the surface that they've run on. But usually, almost always, when somebody presents with their first bout or a bout of tendinopathy, it will be about, in the history, a change in load. So that's really critical. You've got to go looking for that. The other things that you can look at is a previous history. Have you had this before? Have you had it in the other tendon? If this is your right Achilles, have you had it in your left Achilles? And often people will remember having some soreness previously. So they sort of can remember some sort of sensation from their tendon, but it's not been as obvious until they've done something silly and then they present to you with tendon pain. Now, depending on how long they've had tendon pain, what comes with that? So if you've only had tendon pain for a very short period of time, often they haven't lost a lot of function. If they've had tendon pain for, weeks to months, what you will see is that they can't play their sport as well, they struggle to walk any distance, those sorts of things. So they start to lose function. And then the third thing they have is classic sort of tendon signs. So stiffness in the morning if it's an Achilles, sitting in the car if it's a hamstring or a patella tendon, lying in bed if it's a gluteal tendon. So they'll have classic signs that you always should pick up on a history as well.
Okay. Okay, so you mentioned that loading is an effective way to, localize and diagnose tendon pains. So is there some sort of assessment or test so that we can buttress the findings of this from our history?
Yes. So it's really important to remember that your diagnosis is clinical. You don't need imaging. You don't need a doctor to tell you what's going on. You can diagnose tendinopathy clinically yourself. And the history is the first part. Have you done something different? What's your sort of morning stiffness if it's an Achilles? Those sorts of things really guide you to the fact that it's a tendinopathy. But on examination, they must have localized pain. This is really important. So they can't describe pain over a wide area. They have to describe pain with a single finger. So they can point, this is where my pain is. I feel it here. So being very localized is really, really important. If it's more distributed, then you have to think about another diagnosis. So tendon pain is always localized. And the second part about tendon pain is it increases with load on the tendon, and that's energy storage and release loads usually, and it stays localized. So to give you an example, if somebody has an Achilles tendinopathy, they point usually with two fingers, they sort of hold both sides of their Achilles in one spot, and you would say, go up and down slowly on two legs. Do you have any pain and where is it? They're the questions you ask. And they'll say, oh, no, not very much pain. So then you increase the load. So you ask them to do exactly the same thing on a single leg, and you ask them, where is the pain and how much pain do you have? So what will happen when you go to single leg often is the pain stays localized, but it goes up. Oh, that's about 2 out of 10 pain. So then you increase the load again. So you ask them to do some little jumps on two legs, and that's more load for the Achilles tendon. And you would say, how much pain do you have? And they'll say, that's a little bit worse. That's a 3 or a 4 out of 10. Is it still localized? Yes, it's still in the same position. It hasn't spread. And then you do sort of, depending on the person, of course, you would actually then ask them to hop on a single leg, and the pain will go up again and it will stay localized. So what you do with tendons to be sure that you are dealing with a tendon-based pain is to do exactly that. Make sure the pain stays localized, but the pain gets worse with load. That's really important.
Okay. So with respect to recovery from the same pain, how would you determine the optimal load? Is it like an individualized thing? Does it differ from tendon to tendon, or what would it be?
Yes. It's very individual. So can you imagine, let's talk about Achilles because they're easy and are very common. So is a 20-year-old sprinting athlete going to present the same as a 60-year-old golfer? No. So what you have to do is assess these people and see what level of pain they have, what level of dysfunction they have. So again, remember we talked about, if you've had pain for a long time, you start to lose strength and power and capacity to do things. So what we do with everybody is we assess their current capacity. That means, can you hop? Can you jump? Can you change direction? If it's a more athletic person, what do you like going up and down stairs? Can you walk the dog? If it's a more sedentary person. And then we say to them, what do you want to do? And they say, I want to run a marathon. And so we work out what they need to do. And then we make sure we take them from the function that they have at the moment to the function that they need. So it's really simple. It's not complex. It's how you do it that's important. But somebody might start with really low function and need very high function. Some person might start with reasonable function and only need a little bit more. It's just so individual as to what you do.
And like, what would be a key difference? So we understood how we could work it out with Achilles tendinopathy. So what would we do if it's an upper limb tendinopathy?
Upper limb?
Yeah.
Ask someone else, because my expertise is in the lower limb. But there will be differences even in the lower limb. So a gluteal tendinopathy, for example, is a condition of older women, postmenopausal women.
Okay.
So it's not something we see in young athletes, or we don't see it that often in men either. So these women are often very disabled. They can't go shopping. They can't get up and down stairs. So that would be a very different management, because you can't put a lot of load on older ladies who don't have much strength. So you have to find a way to gently load those people compared to your younger athlete or your more active athlete or your more active person who can take much more load.
Okay. So where exactly would we start this?
Okay.
Yep.
All right. So let's use the Achilles again. So you've assessed somebody and they've done something silly a month ago and they've got Achilles pain. You look at them, you can see that their muscle is very small. So they've lost their gastrocnemius bulk. They've got poor strength.
Right.
They've got very high levels of pain when you try and hop them. So they say got 7 out of 10 pain when you hop them. We then would look at their strength. So what we would do is look at how many times on a single leg they could do a slow rise and drop. So what's their strength endurance like? Right. Now, very often in Achilles, we see people who can't actually even lift their body weight. So you ask them to go on a single leg and they actually can't get their body weight up properly. So those people are very weak. So we would start them with probably some double leg lifts to try and get some strength started. And as soon as they can, they go to single leg. So we start with the strength or the function that they have at the moment. What can they do in your clinic? That's where we start our strength work. Now, if they're a jumping athlete and they play basketball and they've got patella tendon, we'd start them in the gym with 40 kilos. So that would be a different starting spot. So we start them with strength endurance, heavy, slow resistance training, but we also start with isometrics. So isometrics are a really good tool to help somebody control their pain. Right. So we would teach them how to do an isometric contraction. That allows them, when they get up in the morning and they've got to, walk a distance to catch the bus to work, to do some isometrics before they go. That relieves their pain a little bit and then they can walk better. So we would use isometrics to do pain relief, but we start them on very much on a strength program.
Is there a particular dose that we use? Say the person has a muscle strength of 3+ or something. So
if somebody, you wouldn't test it with manual muscle testing. It's not helpful. Okay. Everybody with a tendinopathy will have a 5 on muscle testing. You've got to test it in a functional way. So you've got to test how much they can lift their body weight and how many times they can lift their body weight. There's no point testing them non-weight bearing. In a tendon, you need to test them for the calf with a single or double leg heel raise and a hop. For the patella tendon with a lunge or not necessarily a squat, a lunge or maybe on a leg extension machine. Hamstring we do with bridging or something like that. We test that. And gluteal tendon, these ladies often can't even stand on one leg. Right. So there would be a different testing. So it's always mostly in weight bearing and mostly towards a load that person needs to be able to do to be functional. So yeah, it varies.
Okay. So like you spoke about the postmenopausal women right now. I followed your gluteal Trobe trial. It was fascinating. Could you expand a little regarding the exercise protocol that you used?
Yes. So gluteal tendinopathy is, as we say, in older women. And what we find in tendons is you lose function below the level of the tendinopathy. So for people with an Achilles, they only have problems with their strength and capacity in the calf. For people with a patella tendon, it's the quads and the calf. And for people with gluteal tendons, it's the glutes, the quad and the calf. So we tend to lose function all the way down the leg. So we start a strength endurance program for the gluteals, isometrics as well for the gluteals. but also a quadricep strengthening and a calf strengthening program, because it's no point just focusing on the muscle that's affected, muscle tendon unit that's affected. You actually have to make the kinetic chain work. So you need the whole leg to function to be an effective rehab. So you can't just do one muscle tendon unit. You actually have to be thinking a bit more. So we did the calf raises like we do in an Achilles someone with an Achilles problem. We did sit to stand or wall squats for their quads. We did isometric gluteal strength, and then to help them with their pain. And then we did a gluteal strengthening program, which was, doing a single step up. So one foot's down and you're stepping up with the other foot, and this is the one that's being loaded. But you can do a lot of other exercises, sit to stand, single leg sit to stand, a lot of exercises you can do. For most of these ladies, they don't need very much. They're not very functional. They don't want to be functional. They want to be able to go shopping and do the housework and walk the dog maybe. So you can do very low level of exercises for these ladies.
So how did menopausal hormone therapy improve the effect of this?
That's an interesting one. That has just, we did a randomized control trial, so 2x2. So exercise or sham exercise, so proper exercises or pretend exercises, and then hormone replacement therapy or sham hormone replacement therapy. So you could either get active cream and active exercises, or exercises and cream that didn't do anything. And it's just been accepted for publication, so it should be online fairly soon at American Journal of Sports Medicine. And what it showed was that hormone replacement therapy helped ladies who weren't overweight. So if your body mass index was less than 25, adding hormone replacement therapy to an exercise and education program was beneficial. But if your BMI was over 25, it didn't help. So that's Rachel Cowan's work.
Thank you so much, Jill, for this. I would like to ask a specific question, which you might not find specific. So like in ACL injuries, we have a specific injury prevention program for athletes. Is there anything specific, any specific loading pattern that can be followed in order to strengthen the tendon, particularly in order to avoid tendon injury?
Yep, there's a lot you can do. So one of the key things is knowing who has an issue with their tendon. So the biggest predictor of tendinopathy in an athlete, certainly, is a previous history of tendinopathy. Okay, so if you were with a team of 10 players, say 11 if you're in a cricket team, you want to know who's had Achilles problems, who's had patellar tendon problems, because they're the ones that are going to give you trouble. So identifying them is really, really important. Now, if you have identified them, your intervention program is to keep them strong. So for anybody who has a previous history of tendinopathy, we make sure in a sporting environment that they continue to do their weights 2 times a week, all for pretty much the rest of their sporting career. So we never allow them to get weak. We keep them as strong as we can. Now, what that does seems to be keep the muscle strong, of course, which is really important because muscle function is very important in how the tendon works, but also it stiffens up the tendon. If you remember, we talked about the spring and how stiff it was at the start. The heavy slow resistance training or strength work will make that a stiffer spring. Now that's good. We want it to be stiff. The stiffer it is, the better it works. So doing a heavy slow resistance training or a strength training program, knowing the people who have tendinopathy. You could add, if you wanted to know what athletes had pathology in their tendon, because that increases your risk of developing symptoms. So remember we talked that if you don't have pathology in your tendon, you don't develop symptoms. So there might be a whole, so if we, for example, went to a basketball team, 30% of them would have pathology in their patellar tendon, but not all of them will have had pain. So knowing who has the pathology as well as who's had a history of pain allows you to identify those athletes. If you can, then you never change their load. If you go back, remember we talked about in a history, what's the thing that tells us? It is if someone's changed their load. So the last thing you can do with somebody who has a history of tendinopathy and tendon pathology in their tendon is to change their load, because that's going to create problems. So you don't send them away for a 6-week holiday and then bring them back and train them really hard, because that's going to create problems. So if you send them away for a 6-week holiday, you bring them back and you do 2 weeks of very light loading, 2 weeks of a little bit more loading, and then 2 weeks of building up to the load that you need. So they're the 3 or 4 things that you can do to prevent tendinopathy.
Okay, so Professor, you talk about the grading of loads and not letting anyone go off track and go away if you have already, you know that they have a tendon injury. So like I got the exact specific answer: to load it, to progressively load it, to know that they are suffering, like to diagnose, to come to a point that they might be suffering from a tendon risk factor or a tendon injury, and not to yeah, so that's that. Also, if we, as you mentioned, tendon pains are very typical in the start of the webinar. So they have a very typical fashion of pain, like when they start and then they create a post-activity niggle and then it shoots up later in the end. So what are the exact underlying structures within this tendon that causes this type of pattern of pain? Like what?
We don't know.
Okay.
We don't know. If it is the proteoglycans, we've talked about those, they can change within an hour or so, a couple of hours. If it's them and it increases the water in the tendon, that might stimulate the cells, but we actually don't know. So Sean Docking did a study in both horses and humans quite a few years ago now. And what we showed is if we loaded the horse or the human, we saw a maximum change in the tendon at 2 days. And by day 4, it was back to normal. So that the change in the tendon at 2 days suggested some sort of response to load, but we don't know what that is. It's likely to be in the connective tissue within the tendon, and it's likely to be proteoglycan based. So that would be my guess. But we don't know if that's good, bad, or indifferent. Is that bad for the tendon? Is it good for the tendon? Does it make no difference for the tendon? If we get that response, we actually don't have a clue whether we should be, whether we shouldn't be. We don't know why it's there. There's a whole range of things that we don't know. It's there's a lot about tendons we don't know.
So okay, so let me ask you this question: among the risk factors for developing tendon pain, what effect do adipose tissue cytokinins have on our tendon?
Yes. A substantial amount. As we get older, it becomes a little bit more evident that we have a connection between adiposity and tendinopathy. So fat deposition around your middle is bad for you, bad for your health, and it appears to be bad for your tendons as well. And it's likely because of the cytokines, the adipokines, the fat produces. So the fat in your belly will produce somewhere around 120 different cytokines and different signaling molecules, and they seem to have a negative effect across the body, and the tendon is one part of that that's affected. But the other thing that adiposity can do is give you type 2 diabetes or insulin resistance. Now, if your blood glucose levels are high, then that can negatively affect tendon structure because it creates what's called advanced glycation end products, makes the tendon stiffer and too stiff, and not stiff mechanically, just stiff structurally. And that's bad for the tendon as well. So one of the things that you would manage if you had somebody with a tendinopathy would be to try and talk to them about their weight.
Okay. So you just said 2 words which struck me: make tendons stiff mechanically and make them structurally. Yeah. So these are the 2 things which you mentioned. Could you just enlighten our audience? Just a line on this. Just
yeah. Okay. So the mechanical stiffness of a tendon, we don't know where it comes from. It's probably in the connective tissue within the tendon, so not surrounding connective tissue. And what it does is stiffen up the sliding of the collagen fascicles, basically. So when we store energy in a tendon, our fascicles slide against each other, probably makes it a little bit stiffer. And that means that we can store more energy, so our tendon functions a little bit better. So that's a mechanical stiffness. And we don't know if that's where it happens, and we don't know how it happens, but that's the assumption, or that's my assumption at the moment. Structural stiffness through advanced glycation end products occurs sort of in the collagen and between the collagen. So that's at an intrafascicular level. So it's actually not around the fascicles and the connective tissue, it's within the collagen fascicles. And probably doesn't affect the tendon that much in terms of changing its stiffness to mechanical load. So it's the mechanical stiffness that's important, not as much the structural stiffness.
Okay, that was on point. Let me dive in deep to something related to the nervous system. What are the different roles of the central nervous system versus the peripheral nervous system in tendinopathy?
Sorry, could you repeat the question? I had trouble hearing you.
Yeah. So what are the different roles of the central nervous system versus the peripheral nervous system in tendinopathy?
Oh, central nervous system, peripheral nervous system.
Yeah.
Okay. Oh, gee, that's a hard question. You should be asking Ebony that question. All right. The first thing that we know from lower limb tendons is that they are nociceptive, not nociplastic. So it means that it's the peripheral nervous system that seems to play the most important role. Now, in the upper limb, it appears to be different, that in fact, the central nervous system, or the way you process your pain, may be a factor in the upper limb. But in the lower limb, it seems to hurt when you load it and not hurt when you don't load it. So we don't get these nociplastic changes where we process our pain differently. Now, I'm not a pain scientist, so I'm probably saying all the wrong things. But what we know from the research is that lower limb tendons are very simple. They hurt when you load them. Now, what that does, and the most important perspective from a clinician, is because there's such a connection between pain and load, that the brain very quickly learns to unload. So if it hurts, if I poke my hand and it hurts every time, what do I learn to do? I learn not to do that. So if it hurts every time I load my Achilles, what do? I start to not load my Achilles. So I start to change how I push off. I start to load the other leg a little bit more. I have a whole range of strategies. And so as soon as you start to change the loading through your muscle tendon unit because it's hurting, then we start to lose function. We lose muscle strength, we lose power, we lose a whole range of things that you should be able to see as clinicians. And that's what we help when we treat a tendinopathy, is we restore function. And the function is lost because of the pain. So what we see in these people is fear of movement. One of the biggest lower limb factors we see is these people don't like loading. They don't want, you ask somebody with a sore Achilles to hop and they will look at you and think you're mad. They know it's going to hurt, so they don't do it. So fear of movement is one of the things we see. But lower limb tendinopathy is much more about nociception more than central nervous system processing.
Okay, got it. So there are specific clinical questions which I would love to ask you, because according to your web podcast, which I listened to, you highlight there is a very specific way of doing isometrics, and you highlight very specifically that many people do it the wrong way. And I was like, what is the wrong way? I have never been taught a specific way. So would you please enlighten us that what is the specific way of doing isometrics?
Sure. So this all comes from Ebony Rio's work in the patellar tendon, so that's important. Now, before she actually started that study, she did 18 months of piloting or trialing the best load to put on a tendon to give pain relief. And what she found is that it needed to be heavy and it needed to be for a long time. If you did short holds or if you did low level holds, low load holds, it wasn't effective. So what we see in a lot of people clinically is they've tried isometrics, but they've done it for 10 seconds, or they've done it with just their body weight, or they've not done it, or combinations of that. So short and low level loads, they don't work. So you have to, and clinically, we have research evidence for this, but clinically, you have to hold them for at least 30 seconds. And it has to be heavy enough that you can only just hold it for 30 seconds, and it will be muscle that will tell you. So if you have got somebody, let me use a patella tendon, doing a leg extension hold. So they're sitting on a leg extension machine and they're holding. And at 30 seconds, they're still talking about, you know, what they saw on telly last night and having no trouble holding that load, then it's not enough. So the next time you load it, you've actually got to increase the weight. So at the end of the 45 seconds, if you can get them there, can't always get them there, but at the end of at least 30 seconds, they should be able to hold it well, but only just hold it. So they should be going, oh, yep, I can just about hold this. Yeah, okay, there's your 45 seconds. Oh, thank goodness. That's heavy enough, but not too heavy. If they can't hold it for 30 seconds, too heavy. So if it's really light, it doesn't work. If it's really heavy, it doesn't work. If it's not long enough, it doesn't work. So it's got to be, you've got to use your clinical judgment, and you've got to keep changing it. So often it will take us 2 or 3 repetitions to actually get the load right and the timing right. So we'll start them off too heavy, that's no good. Change it, start them off too light, that's no good. Third time, Goldilocks, just the right amount. And then we're looking to see after an isometric set whether in fact they have less pain. So we would expect their pain to change by half or more. So if you hop them and they had 6 out of 10 pain, after isometrics, they should have 3 or less out of 10 pain, if it's tendon pain. So isometric can help us from a diagnostic perspective.
Okay, that was good. I don't know. Am I echoing?
A little bit.
Okay. Okay. So I would want to point out that, you know, as you talked about isometrics, there is isometric, concentric, and eccentric, and a lot of research and like battle is going on that which helps the most to reduce pain. So according to you, what is because I know there is no black and white, it's all grays, but according to you, what is for a clinician when they have to start with a patient, how do they go about it? Like, what do they, when it's like acute, it's a tendon injury which has come in the middle phase of rehab, like it's not acute, so it's post acute. So how do I go about the type of muscle contraction?
Yeah, it's interesting. If pain is not a major problem, then isometrics aren't needed. We use isometrics to control pain. So if the person is functioning quite well and doesn't have a lot of pain, then don't use your isometrics. What you would then do is move to heavy slow resistance training. So either in a gym or even just using body weight loads, which would be concentric and eccentric. So we wouldn't split those up. Both parts of that are very important. You get benefits out of eccentric, but you also get benefits out of doing concentric and eccentric loading. And the beauty of doing both of those is that you really load up the muscle very well as well. So in the early stages of rehab, we're really trying to change the muscle strength and the tendon stiffness, but we can't actually move on to higher tendon loads unless we have a really strong muscle and a stiffer tendon. So the heavy slow resistance, and as I just want to make the point that might be a leg extension with 50 kilos on it, or for some people, it might be just a single leg calf raise 5 times. So it just depends on the level of the person as to how much load you put on them. But what you want at the end of a strengthening program is for the muscle to feel fatigued. You know, the tendon won't tell you anything. You don't get tendon pain when you do heavy slow resistance training, but you want the muscle to tell you whether it's hearing a lot of load. And exactly like we started with, it's the muscle that tends to tell us what's going on. So if I've finished my program that my physio has set, and I actually don't feel anything. You know, my calves aren't tired, and you know, my quads aren't tired. Then you haven't set them enough. You need to finish your rehab exercises and feel like you need a little bit of time off. You need to sit down, have a cup of tea, and have a bit of a relax because your muscles are tired. That's really what we're looking for. So very much what we see in loading programs of people we see that have had other physio input is our default, the thing we do the best is too little load. It's almost never we see someone who's had too much load, but we see people who've been given TheraBand exercises, and you know, they want to play soccer, they want to play football or cricket, and you're giving them TheraBand exercises. You know, there couldn't be a bigger distance between what the muscle tendon has to do with TheraBand and what it wants to do when it's playing cricket. Yeah. You actually have to load them sufficiently so that they can sprint between the wickets, they can turn very quickly, they can bowl, they can do whatever. That's the loads you need to get to that tendon to. You might not start there, but that's sure as heck where you've got to finish. Otherwise you'll fail.
Yes. So continuing this question, does eccentric loading reduce tendon pain, or is it just to make the tendon more resilient?
It doesn't reduce tendon pain much at all. You know, it depends on what research you read. So there's a little bit of evidence that post eccentrics people are better. We prefer isometrics, but the research would support both. The eccentrics, as I say, are a really important part of muscle tendon function, but it's not, we wouldn't use them as a, we would never use, I would never use an eccentric only program. If I had somebody with an Achilles, I would never stand them on the end of the step and get them to lower and then go up onto the Alfredson program. I wouldn't bother. Just get them to go up and down on one leg, and that's a much more effective way of doing it. And you get probably slightly better benefits.
Yeah. Just a second. So we have specific questions regarding, so if we want to prevent tendon associated pain, like if the rehab is going on, what specific things I could do to prevent pain? Like, as you said, reduce the loading. Is there anything more than the load feature?
Keep them, as we've talked about, keep them strong. Okay, being strong is the most important thing to preventing tendon pain. Identify the load that's creating the problem. So you might find that they can train fine until they do sprints at the end of training, and that's what hurts them. So you just take sprints out of the end of training and you rehab them so that they can be more effective at sprinting. The reason that the sprintings are hurting them is because they're not strong enough to do it. They don't have good enough function to do that. So you can't keep asking tendons to do things that they're not good enough to do. So if I asked you to go out and run, I don't know if you're an athlete or not, I don't want to imply that you're not, but if I asked you to go and run 10 kilometres really, really fast, would you have tendon pain the next day? Probably you would if you weren't an athlete, because you don't have the capacity to do it. So that's what you have to do. If someone doesn't have the capacity, you have to take that load out. Other things you can do, aside from strength and changing the load, is make sure they don't change their shoes, make sure they don't change the surface that they work on, because both of those things are still changing load. You might decrease the frequency of loading. So you wouldn't have them training every day, you would have them training every second day. And on the days you're not training, you would get them to do their strength work. So there's a lot of things. And you can use adjuncts. I don't know if you guys use electrotherapy and taping and bracing. I'm sure you probably do. You can use those and they will give you short-term pain relief, but they won't change the tendon in the long term. That's the critical thing. If you just keep doing passive therapies on a tendon, you don't change anything actively. So if you want to run your 10 kilometres that you've tried and you've hurt yourself and you can't, if I then massaged you and gave you some machinery, would you be any better at running 10 kilometres? No. The only thing that gets you better at running 10 kilometres is running. And you might not start with 10, you might start with 2, and then you would do 3, and then you would do 4. So it's logical, isn't it, when you explain it like that, that passive treatments can't change function, and function is what we need to change.
Just one question, since we are, talking about loading. If there is if there is an injury mid-season and the player needs to go back, say you have a 5-day window given by the coach that, this player needs to go up by the 5th today, then what do you do? There is no time to, pace yourself and load the tendon. So then what do you do mid-season?
Yes. Mid-season, it's very hard. The first thing is you don't want to be in that position in the first place. You've started in the pre-season, making sure you're not overloading them and you're getting them strong. If you do have something like that, a lot of isometrics can really help. You would have to talk to the coach about unloading them, so not having that 5-day window, maybe only one very light session of training instead of 2 or 3. You would try and find out why they were sore. So you might change their shoes to see if you can get better buy-in from the shoes. You would strengthen the other leg. You would strengthen the affected tendon. You would strengthen above and below. Even in 5 days, you might get 2 sessions of a little bit of strength work. And then you can use taping and bracing, and you can use your massage and all of those things, as long as you realise that they're only a little bit of icing on the top of the cake. They don't actually do anything. So if the person wants to, have some machinery, that's okay. But as long as you do the things that are going to make a difference as well as that.
Aashi, you're on mute.
Yeah. So there are specific questions about imaging, like in the acute injuries show neovascularization in the weaker tendon. Does this mean that we go slower when we are dealing with such cases?
No, imaging means nothing. It's really important. It doesn't diagnose a tendinopathy, because if I take an ultrasound image of your Achilles and I can see pathology, doesn't mean that your pain is from the pathology, because there's a lot of people with pathology who don't have pain. So you can't look at an image and decide that that person is having pain from their tendon. So it doesn't diagnose. It doesn't tell you how it's going to go. So you can't look at an image, an ultrasound image, and say, oh, that's going to do very badly. You better see a surgeon. You can't tell that. And you can't use it as an outcome measure. So it means that if I do an ultrasound and then I treat you for a month and then I do another ultrasound, it'll look exactly the same. It won't change. So clinically, we very rarely image tendons because it doesn't really help us. And it hinders us a lot because radiologists will tell us things about partial tears and degeneration and longitudinal splits and all of these things that they see in a tendon. And the patient reads it and the doctor reads it and says, oh my goodness, we have a terrible tendon here and it's all going to fall apart and it's going to rupture. And the answer is we can't tell. We have no idea that what is going to happen to that tendon. It is so much more linked to function and to changing the load on the tendon and improving the load capacity of the tendon. The outcomes are linked to that. They are not linked to your imaging. And if someone tells you you have a partial tear in your tendon, ignore it because they can't tell. Sean Docking did this great study. He had an MRI and an ultrasound of the gluteal tendons in ladies, and then he had the surgeon look at the area and he took a bit of histology. They took a little bit of the tendon, looked at it under a microscope. And he looked to see if the imaging and the surgery and the histology matched up. And the answer was they didn't. So if the MRI said, oh my God, it's a complete tendon tear, and the surgeon would say, oh no, it's not torn. And the histology would say, oh, there's a bit of pathology there. It was all over the place. So we have to be so careful about imaging and not using it to mislead us and mislead our patients.
Okay, so it's more clinically driven, and imaging doesn't matter to us as a physical therapist.
Imaging doesn't help us. You should be able to tell clinically if this person has a tendinopathy, how dysfunctional they are, and what you need to do. That's what you need to get out of your clinical examination. And what does imaging tell us? So I've assessed somebody and I've worked out they've got high levels of pain and really poor function. They can't hop and they can't change direction, and that's what they want to do. And I get an image of it. How does that change what I do? It doesn't change what I do. I don't look at it and say, oh my goodness, we can't do this, or we better do this. It doesn't tell me anything.
I agree on point, and I can relate to it well. Okay, so because there's a lot of we are as physical therapists, and the other our peers who are surgeons and whatnot. So it gets a little difficult for the communication to happen, and their understanding about things is a little different than how we perceive things. So there's a barrier between that, which I am, like, as a recent graduate, I'm finding that, and it pains my heart to keep explaining that to the patient, to the athlete again and again. But yeah, we get that.
I have been talking about this in Australia for 25, 30 years now, and I still cannot get the doctors to understand. They still take a picture of a tendon and send the patient to a surgeon. Okay. So you are not in a different position to us. We are still struggling to lose the pathoanatomical tag. Oh, if it's not normal, it must be painful. And if I restore normal, it will get better. And what we know in tendons is neither of those two things work. You can't restore normal tendon structure. That's the first thing. And it doesn't matter if it's abnormal. You may not have pain.
Just two more questions. When you talk about mechanical and structural stiffness, like when you talked about that, so does taking collagen supplements help athletes?
No. Please don't waste your money. Okay? You have enough collagen in your tendon. You have type 2 and type 3 and a little bit of type 1. You have a lot of collagen in your tendon and you turn it over a lot. The thing is, it's not structured. So it's not in nice straight lines, and you can't take load through it. It's all higgledy-piggledy and all over the place. So what's taking collagen going to do for that? It's the cell that controls the structure. It's not how much collagen you have, it's how it's structured, and the cell does that. The cell is abnormal, therefore it can't do it. So it doesn't matter how much collagen you take, you are not going to change your tendon structure, and you would be much better off giving your money to charity or having a beer.
Okay. So coming back to the topic which you said about upper limb. So how does the size of tendon influence the weight bearing, like, and non-weight bearing loading? So like comparison between the upper limb tendon and the Achilles tendon, especially in climbers, like if you're climbing. So
upper limb tendons are obviously smaller, but they take less load. The key thing is that the loads that we see on the lower limb are not dissimilar to what we see in the upper limb. So if you think about our energy storage and release loads, so our Achilles tendon is a spring, so is our medial and lateral elbow tendons. They work as a spring as well. And so does long-headed biceps, so do some of our rotator cuff, not all of them, but some of our rotator cuff. So we have our energy storage and release tendons. We have tendons that have compressive loads. So we see compressive loads where the bone and the tendon join. So we see compressive loads in both the lower and the upper limb. And we have friction loads. So if you think about, you can get a perineal peritendon problem or a tib post peritendon problem. You can get a biceps, long-headed biceps peritendon problem. So the loads are not different. The response of the tendon, the pathology is the same. So you can't discriminate lower limb from upper limb tendon pathology. Where I think I lack ability is I'm not as good a clinician in the upper limb as the lower limb. So I think if you want to talk rotator cuff, you need to talk to Jeremy Lewis or Joe Gibson or someone like that who've done a lot of that. But in terms of the pathology, the loading mechanisms, the way that you would manage a tendon, it's not different. It's just that there are quite specific skills around diagnosing and managing them.
lastly, we talk about optimal loading post tendon repair. So is it always the trial and error approach?
Yes, to some extent. As you do more and you become a better clinician, you make less errors. You make fewer errors. So I think at the start you might get it wrong. And as I say, you always to unload. You never overload a tendon. You always unload them. So I think what you can do is you can try a load and you can watch in the clinic how that person responds to the load, and you can see if they're any worse the next day. If you don't feel that you've got a response, you can increase it. But I think aside from not giving people enough load, the issue is people don't progress it enough. You know, you can't just give eccentric drops off the edge of a step to a sprinting athlete because you're not taking them up to the sprinting loads that they need. We have to go through the strength and the strength endurance and the energy storage and release and the energy storage release endurance. So if I come back to anything, it's about setting that tendon up to be capable of tolerating the loads that it needs in sport. If you can't run your 10 kilometers and you go out and try and run 10 kilometers again, you'll fail. So I have to get you running 10 kilometers before I send you out. It's no good half baking or half doing a tendon rehab and sending them back to sport because it's just going to fail every single time. That's what we see.
Okay. Could we talk a little bit about prognosis? Because that's like a very, very tricky place to be. So if you talk about, can you hear me?
I just missed what you said, a tricky place.
Okay. A very tricky word, prognosis.
Prognosis, yes.
In terms of tendon injury. Yeah. So because I realize your favorite research topic is around gluteal and the patella. Could you like just put some light that how do we go about prognosis and what are the things that could help us in understanding clinically, like the clinical complaints or like with the progress, like how do we go about
it? Okay. It's actually easier than you think. So if somebody comes in and they have high levels of pain and really, really poor function, they can't stand, if it's gluteal, they can't stand on one leg, they can't go up and down stairs without massive amount of pain, and you look at their leg and they've got real wasting in their glutes and their quad and their calf on that side, then you can help them because all you are doing is restoring their capacity and their ability to function. The people I can't help are the people who have good function. So they have high levels of pain or levels of pain, they have pain, but they haven't lost any function. Now, as soon as I see that, I know it's not tendon, because remember we said that tendon pain causes you to unload and unloading causes you to lose function. So if somebody came in and they had really, really sore elbow, but they could, they had equal grip on both sides, for example, and you couldn't get any, picking up things didn't make them sore, you'd be looking in the elbow joint because it's not the tendon that's creating the problem, because they have good function but pain. So the prognosis is related to how much dysfunction they have, and the length of time is related to how much dysfunction they have. So if they come in and they can only raise their body weight 3 times, it's not uncommon on a single leg for an Achilles, and they want to run a marathon, how long is that going to take me? It's going to take me months, because I have to retrain everything and get it strong and endurance and ability to energy store and ability to run 5 kilometers, then 10 kilometers, then 15 kilometers. That's a long time. But if they come in with a little bit of pain that hasn't been there for a long time and they're just not quite at the levels they need to be, and all they want to do is walk their dog, then I can turn them around in weeks. Okay? Because what they have and what they want is not that different. So it's very easy to gain a little bit of strength and capacity in the tendon and in the muscle tendon unit, in the connect chain, in the brain. It's easy to regain that. So prognostically, it's actually very simple.
Yeah. So taking back home, capacity, performance, and the whole link, right from the brain to the tendon, Like every element has to be tackled in its own way while we are in the rehab. That actually determines the prognosis. And
Yes.
yeah, you
Yes.
put it down there easily, but still in my brain, I'm still scared. I'm still scared to tackle all of them. But yeah, that was it. I am so glad that you answered all the questions so painstakingly and with so much ease. And looking at all the comments here, I am feeling so grateful to have you here. Everyone is getting pearls from you about the isometrics, about the consent, like many things which we didn't know. Even as clinicians, there are many clinicians, researchers, academicians here online with us, but they still, like, we are grateful to you to have you here. And you would love the participants if you all share, if you all fill the feedback form, which we, regarding the webinar, which we had with her, so that we come to know, we come back to you with more such stuff, and we get more people like Jill, and Jill later, if she's free, for some other enlightening thing. Also, we're going to send mails regarding the takeaways from this webinar. We are going to sell some of Jill's work, like what the links or some of the write-ups which we have of Jill's work that could really help you to take back home. And that would only happen if you help us with helping us out with the feedback form. The links are all there in the description. And it was an honor to have Professor Jill Cook and all of you here with the Physiozest. Please subscribe to our magazine, because we do have such perils. We have works. We have got inspired from Ebony's work. We've got inspired from Jill's work, which is going to come in the next editions too. So that's that. Thank you so much for being here, guys. Bye.
Thank you so much, everyone. See you later. Bye.